Good day, ladies and gentlemen, and welcome to today's webcast entitled Bipolar Disorder in Adults. If you would like to ask a question during the webcast, you may do so by clicking the Ask a Question button located below the presentation. Simply type your question in the box and hit send. At this time, it is my pleasure to turn the floor over to your host, Susan Weinstein. Ma'am, the floor is yours.
Well, thank you very much, Kat, and hello, everyone. I'm Susan Weinstein, the Director of Programs and Marketing at Families for Depression Awareness, and it's my pleasure to welcome you to our Bipolar Disorder in Adults webinar. We really appreciate that you're taking the time to join us and learn about bipolar disorder and how you can help someone. We appreciate you spending your valuable time with us. I have several housekeeping items to share, but they won't take long. To view this program, make sure you've disabled your pop-up blocker. Know that you can download a handout of the slides from today. Click on the materials link on your screen. This webinar includes 3 brief videos. If you don't see them, don't worry, because you can access the videos through our website after the webinar concludes. We're looking at having an hour for the presentation, followed by 15 minutes for questions and answers. So I hope you build that into your schedule. And so that we have plenty of questions to answer, be sure to use the Ask a Question button and submit your questions to Dr. Youngstrom. We'll be monitoring the questions throughout the program, so feel free to submit your questions whenever it's convenient for you. As the webinar concludes, we'll send out a link to our online survey. We really appreciate it when you take a few minutes to give us your feedback. You'll help us improve our program, and we'll thank you by sending you a free copy of our Bipolar Disorder Stories of Coping and Courage brochure. If you find that this webinar is helpful to you, please feel free to forward the link to your friends and colleagues. The recorded webinar will be available for viewing for a limited time on our website. Finally, we hope that you'll help us reach more people by making a tax-deductible contribution to Families for Depression Awareness. Today, I'm thrilled that our expert presenter is Dr. Eric Youngstrom, a licensed psychologist and professor of psychology and psychiatry at the University of North Carolina at Chapel Hill, where he is also the acting director of the Center for Excellence in Research and Treatment of Bipolar Disorder. He consulted on the 5th revision of the Diagnostic and Statistical Manual, the DSM-5, and the International Classification of Diseases, the ICD-11. Dr. Youngstrom has published more than 240 peer-reviewed publications on the topics of clinical assessment and emotion, and he has served on prominent editorial boards as well as providing ad hoc reviews for more than 70 psychology and psychiatry journals. I'd also like to introduce Marlin Collingwood, the Executive Director of Families for Depression Awareness. Marlon joined the Families for Depression Awareness staff in June of this year, and he has more than 25 years' experience in public relations and communications. Most importantly, Marlon has a strong personal commitment to the FFDA mission, having cared for his husband, Gary, during his struggle with depression. Dr. Youngstrom, thank you so much for being here. Let's get started.
Thank you, Susan, for that very kind introduction and for the opportunity to be here. And I would like to echo the thanks to the audience clearing their time to get together this evening to talk about this crucial topic. So our goal for the evening is to talk first about bipolar disorder. What exactly is it? What do we know about this condition? And then get to treatment and recommendations for getting help for ourselves or for someone that we care about who is living with illness. And talk about how you would manage that, how you would finesse that if someone is reluctant to get help, either because they don't see the problem in themselves or because they're embarrassed or feeling the stigma associated with the illness. We'll talk about resources like Families for Depression Awareness and then move to the question and answer section. So bipolar disorder is the current name for an illness that we've been studying for more than 100 years. We used to call it Manic Depression, and the name has changed, but the symptoms of it are still very much the same. We now know that this is a condition that affects 2.5% of the population in the United States. This makes it twice as common as schizophrenia, twice as common as autism or diabetes. And when we talk about bipolar features, it could be as many as 1 in 25 people. So just to give you a sense of the numbers that we're talking about, there are more adults in the United States living with bipolar disorder than the combined populations of Chicago, Philadelphia, and San Diego, more than the population of many entire states in the United States. And because it's so common, it affects many more people than you might think. This includes neighbors and friends and relatives, and also a lot of famous people, actors and politicians, and people who have sometimes gone on to have great success. One of the definitive studies of this was done by a psychologist named Jameson, who wrote a very influential book called Touched with Fire, which was a study of the association between bipolar disorder and tremendous creativity or productivity in the arts and politics. Interestingly, Jameson herself has bipolar disorder, as do many other prominent figures like Ted Turner, Maurice Bernard. There's a lot of discussion about historical figures like Vincent van Gogh or George Friedrich Handel, the very prolific composer who wrote The Messiah, the one that goes, Hallelujah, that one. And what we know now is that bipolar disorder is a medical condition. The way that my group is thinking about it more and more is that it's brain disease, very similar to heart disease, many very similar risk factors and associations with lifestyle. And like our current thinking about heart disease, we're recognizing it's a condition that needs to be monitored to some degree, will be with you for the rest of your life. What is an important feature to keep in mind about this is that it's an episodic condition, so it will appear to come and go, and there may be periods where the person feels fine and looks fine and may function very, very well. The problem with the condition is very high risk of relapse. What we also have learned is that this is a highly heritable condition, and so we see it run in families. And this speaks to it having both a genetic component but also an environmental component. The heritability not completely due to genes alone. You think about it, things like speaking English. The fact that I'm speaking English is because my parents were speaking English, and so the shared environmental experience also plays a big role in the heritability. So bipolar disorder is fascinating because it has this potential association with creativity and productivity, but it has a tremendous downside as well. If it is not properly treated, bipolar disorder can lead to very high rates of alcohol and drug use. It's associated with very high risk of unemployment. It doubles or triples the risk of never getting married or being separated or divorced. It also increases your risk of homelessness, of bankruptcy. It quadruples the risk of psychiatric hospitalization and quintuples the risk of suicide attempts. So it is a very serious condition, and studies of the global impact of it consistently put bipolar disorder in the top 10 for biggest causes of disability, both in developed countries like the United States and Europe, and in developing nations as well around the world. So the very important good news is that bipolar disorder is treatable. So we don't have a cure for it yet. So the types of treatment that we're talking about are things that can be very powerful in reducing the symptoms and improving people's functioning, but not going to eliminate it and not going to be able to guarantee that there wouldn't be a recurrence. With medication and therapy, it's possible to not just survive the illness, but to thrive and sometimes do extremely well. One of the challenges, though, is that bipolar disorder is often not diagnosed. More than 7 out of 10 cases of bipolar disorder, when they seek help, are first told that their issue is due to a completely different illness. Very often, people will seek help when they're depressed, and the clinician will recognize the depression, but not dig deeper to determine whether or not it's an ordinary unipolar depression or whether it's the depressed phase of a bipolar illness. People often have it misdiagnosed as attention deficit hyperactivity disorder when they're more hypomanic and have more energy and more difficulty staying focused on a single thing. And the very high rates of substance use and alcohol consumption associated with it, people often focus on the substance and don't dig deeper to realize that there is a mood disorder that actually is driving the substance use. A third of people with bipolar disorder spend 10 years dealing with very serious mood issues without getting proper diagnosis of bipolar disorder. And without that diagnosis, the well-intentioned treatments that people will be recommending and people will be trying are not likely to be what the person needs to become stable again. So to give you a sense of what it's like living with bipolar disorder, the American Foundation for Suicide Prevention has shared this video with us. Will you please go ahead and have the video?
Starting video.
I had a manic state before my depressed state. For my first episode, it was a lot of drug use. I cheated on my boyfriend at the time. I destroyed friendships. And then I was depressed afterwards when I realized what all I had done. I had a scooter. I was on a motor scooter and I had a motor scooter accident. And I got really depressed after that. Depressed to where I was having suicidal thoughts. And the doctor I was seeing, he didn't know how to treat me correctly. So he recommended that I go to stay in a hospital for a while and see if they could get meds regulated and see exactly what was going on. That's when I first found out that I had bipolar.
You may continue.
So this is a condition that used to be called Manic Depression, and the face that it shows us looks very, very different depending on whether we are working with the up phase or the down phase of the illness. When people are hypomanic, which is a mild form of mania, or all the way manic, the things that people might notice are a big increase in energy. And that increase in energy is something which is easier for people to notice in themselves, more so than the change in mood. That higher energy doesn't have to be positive. Mania doesn't have to be fun. It also is possible to have a great deal of energy and be very, very irritable and have a very short fuse. Another feature of mania is not needing as much sleep. And people will get less sleep and not feel tired the next day, not miss the sleep. And that high level of energy also sometimes can feel like a tremendous amount of restlessness and not being able to sit still. And sometimes people describe feeling like their brain is running faster and their ideas are racing through their mind. People will talk very, very quickly. And sometimes people will say that even though they're talking faster, their mind is pushing words into their mouth even faster than their tongue can keep moving. I'm not saying that this person has bipolar disorder, but I've seen interviews that are a beautiful example of what this sort of pressured speech would do. If you've seen interviews with Quentin Tarantino, when he gets very fired up about a topic, he starts talking so rapidly an interviewer can only hope to get a word in edgewise. And another feature that we see with mania is becoming very easily distracted. And some of Kay Jameson's research suggests that might be a part of the hypomania or mania, which is associated with that increase in creativity, where people have more divergent thinking and see connections or weave things in that other people who are more focused might not pay as much attention to. What other people are likely to notice when someone gets hypomanic or manic is an unrealistic belief in their own abilities, sort of grandiose thinking. So people will believe when this gets very extreme, this is where people start to believe that they're on a mission from God, or they have unique special powers and abilities. And mania also clouds judgment, and people will often engage in behavior which is fun without paying attention to the risks and the potential harmful consequences. And mania leads to a lot of impulsivity, and so these are the spending sprees and the sexual promiscuity and indiscretion and gambling and speeding. And this is the behavior that often becomes hard to tell, is this a mood disorder, or is this a conduct problem or antisocial behavior, as we get into the sort of impulsivity where people are breaking the law. And on the other side of manic depression, we have the depressed states. And depression would be a period where the person is extremely sad or irritable or hopeless and down. And the irritability is not the first thing that people think of when they think of depression, but it often is what the depression looks like, especially in teenagers and children, and especially in young men. And so the presentation here, a person is depressed, and you ask them, do you feel depressed? No. How do you feel? Fine. And so it's a very irritable, grumpy presentation. Another core feature of depression is not enjoying things that you used to enjoy, and losing interest, not feeling like doing things that you previously found fun. And that, the technical name for this is anhedonia, not being able to enjoy things that you used to. And that's one of the hallmark features of serious depression. People who are depressed also tend to have very low energy, opposite of the high energy that we see in hypomania or mania. Also can have trouble concentrating or remembering, but when a person is hypomanic, they're very distractible, and other things are grabbing their attention. When people are depressed, the problems concentrating or remembering things, they describe the brain feeling in slow motion or sluggish, or they're ruminating. They're dwelling on, my life is terrible. The forecast is continued loserdom for the next several weeks. And they're just thinking, they're dwelling on how negative things seem to them, and they're not paying attention to the things that are happening around them. It also is possible to have a lot of restlessness with depression, and here this starts to shade into the difficulty staying still that we see with hypomania. Also very likely to see changes in sleeping or eating. Some people who are depressed sleep a lot less. They have trouble falling asleep or staying asleep, and they may lose their appetite. Other people who are depressed, it goes exactly the opposite way, and they will sleep much more than usual or eat a lot more, often very high carbohydrate or comfort foods. And another associated feature of depression, unfortunately, is thoughts of death and suicidal ideation. And depression is one of the leading risk factors for attempting suicide. So bipolar disorder could look like the highs of mania or the lows of depression, or it could mix both of those together at the same time. And for me, studying to become a clinician, this was one of the most confusing things. How could you be up and down at the same time? The technical name for this is a mixed state, and there are two different ways that this could happen in a person. The technical names for them are dysphoric mania and mood lability. My nicknames for them are the chocolate milk presentation and the fudge ripple presentation. In the chocolate milk mixed state, you take your milk of mania and your chocolate of depression, and you blend them together, and what you get is something new. And the point of the metaphor is that you couldn't put your finger in the glass and say during this part of the day she was manic, during this part of the day she was depressed. It's all this new chocolate milk mixed state, which is very high energy, like a classic mania, but very negative. So you have all of the energy of the mania and all of the hopelessness and despair of the depression, and this is a very high risk factor for attempting suicide because you have, again, all the pain and negativity of the depression and the activation of the mania. So you have the negativity and the energy to act impulsively on it. The other type of mixed state, the fudge ripple mixed state, you're taking your milk of mania and your chocolate of depression and, again, twirling them together. But here you can still see the ripples. So the point of the metaphor is you could talk with a person and say during this part of the day they were depressed, during this part of the day they were manic, and their mood is going up and down within the course of the same day. And our diagnostic systems say, is a person doing this much of the day? Yes, 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 yes. And as we look at a week's worth of the ice cream, are they doing it most of the week? Uh-huh. And so that would meet criteria for a mixed state. And that fudge ripple mixed state is the sort of presentation that when people talk with a doctor, we're scratching our heads trying to figure out, is this a mood disorder? Or is this something like borderline personality where it's black, it's white, I love you, I hate you, you're the best therapist ever, you're fired? And so what does bipolar disorder look like? Well, it could look like a pure mania, or it could look like a pure depression, or it could look like one of those chocolate milk or fudge ripple mixed states, or it could look like you're fine. If you're euthymic, again, an episodic condition, and if people are fortunate, then they're able to balance their lives again and get back to that euthymic baseline where they're not too high, not too low. And one of the things which makes it so complicated to get the diagnosis correct is that for bipolar disorder, we need to understand not just why are you at the clinic today, what do you want help with right now. Instead, we have to play lifetime mood bingo. So it is not just are you manic right now. To recognize a diagnosis of bipolar 1, we have to switch and ask not just today, but lifetime. Have you ever been manic? And it only is after we have worked through the complete lifetime mood bingo card, have you ever been manic? Have you ever been hypomanic? Have you ever had a depression or a mixed presentation? Only then can we go to round 2 in DSM or ICD and say, okay, let's make a mood disorder diagnosis. So bipolar 1, one of the options for a diagnosis, the requirement is you have to have at least one manic episode at some point during your life. Now, what I want to underline here is this is an illness that we used to call manic depression. And according to the criteria, you don't ever have to have a depression to be diagnosed with what we used to call manic depression. That's part of the argument for changing the name to bipolar disorder. So the key feature for bipolar 1 is that at some point in your life, you've had a manic episode. Bipolar 2, to make this diagnosis, we have to have 2 chips on the lifetime bingo card. One of the chips will be on a major depressive episode, and the second chip will be on a hypomanic episode, one of those milder, not all the way to a full-blown mania episodes. The hypomania is what tells us that the depression that we're seeing is not an ordinary depression. It is the depressed part of a bipolar illness. And people with bipolar 2 can't ever have had a mania. Why not? That would be a free upgrade to bipolar 1. When someone has bipolar disorder, as if it weren't hard enough keeping track of all of these different mood states and the lifetime presentation, not just the why are you here in our office today, bipolar disorder creates a whole bunch of other issues and problems that often can look like a second diagnosis or maybe a part of a co-occurring issue. So people with bipolar disorder show lots of impairment in executive functioning, which is a fancy word for our ability to plan and follow through on those plans and to keep things in our memory and use our memory and our planning to solve complex problems. As we said earlier, also see very high rates of substance use, and very common for people with bipolar disorder to also have very high levels of anxiety and stress in their lives, which can often reach the point of panic attacks, and if their impulsivity or bad luck leads to traumatic events, then also very likely to develop post-traumatic stress disorder on top of the mood disorder. So we have an illness which is more common than we realize, causing a huge amount of chaos and disruption in people's lives. But because it is complicated to diagnose, literally taking decades for many people to get a good diagnosis and a treatment that really is likely to help make a dent in this. So how do we do a better job recognizing bipolar disorder? What we need to look for are big changes in mood and energy and behavior. And we may also notice problems in executive functioning or big increases in substance use. People who seek help for depression and get prescribed an antidepressant may hypomanic or manic symptoms. And another thing that's a very important clue in a detective story of trying to understand what we're working with would be the family history of mental health. Again, because bipolar disorder is so heritable, if we do a good job gathering the family history, that often gives us a hint or a strong signal that the mood issues and the substance issues that we're working with may actually be part of a bipolar illness. So once we've recognized that we're working with bipolar disorder as opposed to typical unipolar depression or ADHD or something else, what will we do to customize the treatment? We do have at this point some very well-established treatments for bipolar disorder, and these include medication as well as psychotherapy. And we're learning more and more, again, very similar to heart disease, that lifestyle matters a lot. And cultivating a healthy lifestyle with a lot of attention to exercise and to diet, but especially to sleep, can do a huge amount to stabilize the condition and to keep people from relapsing for longer and longer. So the best treatment is going to involve multiple components. Medication by itself is not going to be enough, nor will psychotherapy or diet and exercise. So when we're working with bipolar disorder, our first goal is to get the person stable so that they're no longer a danger to themselves or others. So safety first, and once the safety issues are addressed, then the next step is to work to further stabilize the mood, get the person on as even a keel as possible. And then the third pass would be to work on whatever other symptoms or issues are left after the mood issues have stabilized. So it is not uncommon for people with bipolar disorder, if the treatment does a good job of addressing the mood and getting them on an even footing again, to see what looked like an attention deficit issue, where there's problems in executive functioning, clean up as the mood symptoms go away. But it's about equally common for the mood symptoms to get stabilized and for the person to still see issues with executive functioning or concentrating. And so that suggests that there may be a second issue. And again, comorbidity is pretty much the norm, not the exception with bipolar disorder. And so if it looks like there are still leftover symptoms of anxiety or attention problems, then additional treatment, adding in another component to deal with those specific leftover issues, makes a lot of sense. When we recognize that it really is a bipolar disorder, the treatments that we use are different than what we would use for unipolar depression. So we're very likely to see prescriptions of mood-stabilizing agents like lithium or anticonvulsants, atypical antipsychotics, which doesn't mean that the person is psychotic necessarily. They're very effective at reducing the manic symptoms and stabilizing the person's energy. And again, medication often is prescribed for the co-occurring conditions, the anxiety, the insomnia, the attention problems. And if the person has developed serious substance misuse issues, there may be medication that will help to stabilize that part as well. There's a lot of concern around using antidepressants if the person has bipolar disorder. And the challenge here, again, is people, especially people with bipolar 2, are very unlikely to seek help when they're hypomanic, much more likely to ask for help when they're depressed. And so if we don't do a good job with the evaluation, if we don't play lifetime mood bingo, have you ever been hypomanic, we may not realize that the depression that we're working with is actually the depressed phase of the bipolar disorder. The antidepressants that work reasonably well for unipolar depression don't have a big effect on bipolar depression, and it's very likely that someone taking an antidepressant for a bipolar illness will get hypomanic sometime while they're taking the medication. There's debate about whether the antidepressant actually is triggering the switch. Most studies that have a comparison group and a double blind where the person doesn't know whether they're getting an antidepressant or the placebo show identical rates of hypomanic symptoms. But the data are quite clear. Antidepressants don't help the depression as much if it's a bipolar depression. So if someone is talking to a clinician and the clinician is recommending a medication, there's some very helpful questions to ask to really understand what's the rationale behind the particular medication. It's very appropriate to ask things like, I'd like to understand why you recommended this particular medication, and are there other alternatives that we should also talk about? what's the particular purpose of each medication that's getting prescribed? Is this something which is going to help with the mania or with the depression? Usually, medications are more effective for one or the other pole of the illness. And in adults with bipolar disorder, it's very common to need to prescribe two medications, one to stabilize from above and attack the mania, and one to stabilize from below and reduce the depression. Another very important discussion to have is what the side effects are, and to know what are the common side effects, but also what are some of the more worrisome side effects, even if they're rare. And it's crucial to know what things should you be watching for and how quickly should I contact you if I start seeing some of these side effects. And the good thing with the medications, particularly for the ones that help with mania, is if they're going to have an effect, you usually can tell very quickly. For reducing mania, we often see a signal in a matter of days or a week. And for reducing the depression, usually it takes a bit more time. Usually 2 weeks, 3 weeks is enough time to have a clear sense of is the medication helping or not. And they're very, very short checklists and rating scales that are available for free. Family Aware has gathered several of these and made them available on their website. And it's a very helpful tool to use to get a sense of, is the treatment helping in the way that we would hope it would? There are a variety of talk therapies for bipolar disorder, and surveys have identified more than 500 different types of psychotherapy. They're not all equally effective, and they're certainly not all equally effective for bipolar disorder. The ones that work best are going to be the ones that have clear skills that will help you manage your emotion and get your interpersonal relationships and your daily routines into a regular rhythm. The ones that have the best evidence are things like cognitive behavioral therapy or dialectical behavior therapy, family-focused therapy with a lot of emphasis on communication and problem solving, and interpersonal and social rhythm therapy is one which, in addition to the coping skills, pays a lot of attention to scheduling exercise, regular interaction with friends, and getting on a regular sleep schedule, and education about bipolar disorder and really learning about the medications and the different components of therapy magnifies the healing power of each of these components. All of the talk therapies are most helpful when the person has been stabilized, usually with medication. So medication is very powerful at reducing the mania and the mixed presentations, and it's when the person has stabilized that they're able to absorb the skills and the ideas in the talk therapies. Once you get onto an even keel, it's important to have a plan how you're going to stay there and maintain your wellness. And here the key skills are getting on a regular sleep schedule and staying on your medications, avoiding alcohol and recreational drugs. And more we're really seeing big benefits from exercise in terms of improving your mood, but also reducing your blood pressure, reducing the inflammation. And the inflammation, we think, actually plays a causal role in the worsening of depression and other symptoms of bipolar disorder. Tracking your symptoms or monitoring your mood and your energy on a daily basis is a very, very easy, very powerful tool to maintain your wellness. And continuing in therapy, a very important way of supporting yourself. So we have another video clip, courtesy also of the American Foundation for Suicide Prevention, about living with bipolar disorder. May we please have the video?
Playing now.
The thing that helped me most with my bipolar was not being afraid to try new things, try new medicines. I have a wonderful support system at home. My boyfriend, he's very aware of my episodes, and sometimes he will tell me, hey, you need to check yourself. I think you're cycling. And I stop, and I'm like, okay, yeah, because he's usually right. He's so supportive, encouraging when I feel like the smallest person. He helps and builds me up.
You may continue.
So the medications and the therapies don't do a person any good if they don't know where to find them. So how do we go about getting help? If the person's energy and mood are so extreme that safety is an issue, that's a 911 call that needs to be made. If there are concerns about bipolar disorder that are not to that degree of emergency, then you want to make an appointment with a mental health provider, a psychiatrist who can conduct an evaluation. Unfortunately, general practitioners and family practitioners and most psychotherapists won't have enough experience working with bipolar disorder to be able to really be confident in making the decision. So talking to a psychiatrist or someone with a strong psychiatric or mental health background, very important in getting an accurate diagnosis. If the person that you're concerned about is manic, what you want to try to do is stay calm and keep your energy level low and not get dragged into raising the emotion and cycling upwards. You want to avoid long conversations, definitely avoid arguments. As much as possible, you want to position yourself as on their side. And if they see you as being on their side and trying to help them, it'll be easier to get them to a place where they can be helped. You don't want to get caught up in their grandiose ideas, and you want to focus on what you can do to reduce risky behaviors and situations, whether that is accompanying them or taking their credit cards and car keys and setting them aside. And again, if things escalate and they become a danger to themselves or to someone else, very important and very appropriate to call 911. Once you get the person to agree to go for treatment, you want to think about how you're going to pay for services. Health insurance will cover the services. You can talk with people about getting reduced fee services. Many clinics offer a sliding scale. It may be possible to pay out of pocket as well. You'll want to build a list of referrals. Ideally, you want to have more than one option to choose between. And this is another place that advocacy groups like Families for Depression Awareness can be a huge resource. They have a Get Help page that's very helpful in locating professionals in different regions all around the country. There are care consultations for families in Massachusetts, and different states are going to have different resources available. And you can also call clinicians or clinics or helplines and ask them if they can help you. And if they say no, not appropriate, ask them, who would you recommend instead then, please? And for people who are living with bipolar disorder, both education and support are going to be crucial. So education and understanding and demystifying this condition helps to make sense of the extreme highs and lows and dramatic changes that people have been experiencing. And here, too, advocacy groups and websites like FFDA provide a huge amount of information that's very accessible, very readable, and available at no cost. And support, not just for the person living with the illness, but also their significant other, their family members. very important because fighting bipolar disorder is not going to be a sprint. It's going to be a marathon. And so you want to have people that can pick you up for the long haul. Advocacy groups have organized peer specialists and mentors, and often churches and temples and other social groups will have support available. And your network of friendships and professional relationships and your spiritual and religious groups, all of your social network is going to be tremendously important in keeping you grounded and energized for the long haul. Another great suggestion is to make a written plan about how you want to deal with the highs and the lows. Because bipolar disorder is episodic, when a person is relatively stable, is a great time to come up with a plan how they're going to manage the ups and the downs. So in advance of the hypomania, saying, I'll let you take away the car keys, or I will not make an investment unless I talk with two friends, you and someone else, and you both say, yes, that would be a good idea. So having a written plan so that it doesn't become an argument as the person gets hypomanic, and having an advance directive about what to do if the person becomes severely depressed or experiences one of these mixed episodes, and is not able to provide informed consent for how they would want their treatment managed at that moment. And another challenge in working with bipolar disorder is that when people are caught up, this is an illness that involves extreme moods, and that compromises our awareness of how our behavior seems to the people around us. And so it is a very common scenario for someone to get hypomanic or in one of these mixed states and not think that they have a problem at all. So how do we help someone who clearly needs help but is reluctant to get treatment? What we need to do is be supportive and show compassion and recognize that this is difficult. And as I mentioned earlier, another huge issue is stigma and embarrassment, feeling like my life is not completely in my control. It can be helpful to note that this isn't just one person's problem. This is something that affects everyone in the family. And so it's not just this would be good for you. This is good for everyone. This is what is in the best interests of the family, the children, and mobilizing other people and getting multiple people who care to present a united front and being persistent. Don't just say, you ever considered getting some support or some help for this? No. Oh, okay. I just thought I would ask. You need to plan on knocking at that door repeatedly. You also want to be realistic. The person, if they're seriously depressed or manic, they're not going to be able to do as much for themselves as we would wish. So it's important to be able to step in and be an advocate. And navigating healthcare for anything, for a dental crown, for diabetes can be extremely complicated and confusing at this point. When someone is extremely stressed or their mood is very activated, it's going to be almost impossible sometimes for them to navigate the healthcare system on their own. It'll be important to recognize that it's appropriate to be firm and to limit privileges or limit financial support until the person gets treatment. And when my wife was starting graduate school, I worked in sales, and one of the techniques I was taught was what's called an alternate advance. So you pick the menu, and you give the person the control over the choice. Do you want Clinic A or Clinic B? So they still have some control. They still have a choice, but you're picking the menu of acceptable options. And as I said earlier, dealing with bipolar disorder, we don't have a cure. This is not going to be a quick sprint. This is going to be a marathon. And so it's crucial that you think of ways that you're going to take care of yourself when a loved one doesn't get help, or they get help, but again, not a cure, and it doesn't help as much as you would wish. It's crucial to have a place that you can process your feelings. It's crucial that you have support for yourself outside of the partner who is living with illness. And you look for alternatives, and as much as possible, stay hopeful. Again, a tremendously debilitating condition at the height of the episodes, but an episodic condition and a great deal of recovery is also a very real possibility. We have our third and final video.
Playing now.
So I also have a lot of things I do to take care of myself. I garden, I knit, I do various other social activities, but I have a really good circle of friends. But when my son got hospitalized the first time, a friend of mine called me and she goes, "How are you? What are you doing?" And I said, "You know what I'm doing?" And she says, "You're weeding." And I said, "No, actually, I'm dividing peonies. Do you want some?" So she came over and took my peonies. But yeah, you have to, physical activity is really important. So for me, gardening is that's what I like to do. And it's really important to do that. Other people walk or go to the gym or do yoga or Tai Chi, but you have to build into your day, every day, something for you. Even if it's just soak in the tub, soak it in a bubble bath, you have to do something every day, or you're not going to make it.
You may continue.
Hello, everyone. This is Marlin Collingwood, Executive Director of Families for Depression Awareness. First off, I want to thank you all for joining us, and do hope you were able to find some useful information from Dr. Youngstrom. And Dr. Youngstrom, thank you so much for taking time out of your busy schedule to do this in very, very important webinar that's going to help hundreds of people who are listening in now and who will be listening in the future. I just want to take a few moments because we want to get right to your questions to talk a little bit about Families for Depression Awareness. We are a national nonprofit organization. We serve about 80,000 families a year, and we are the only national nonprofit that focuses specifically on the families who are dealing with a loved one who might have depression, bipolar disorder. We work to get families well, in turn to get their loved ones well, and to prevent suicide. We have a variety of different resources that I'm going to talk about in a minute on our website that we'll take you to. If you go to our website, which is www.familyaware.org, you'll see a variety of resources, including stories and interviews, many of which really jump off of many of the things that Dr. Youngstrom talked about tonight. They include expert videos, audio and written, everything from family communications to how to find and pay for treatment. There are also some really moving and I think important personal stories about folks and families who have been dealing with depression, bipolar disorder, and how they've managed it. One of the things that Dr. Youngstrom did mention early on was that bipolar disorder does have a hereditary aspect to it oftentimes. And one of the things that a lot of families have found very useful is our mental health family tree, which really allows you to chart your family history of depressive disorders, bipolar disorder, and depression. And we'd encourage you to go to our website and look at that section and look at where your family mental health tree might be helpful as you're looking at what the help that your loved ones might need. And this webinar was one of about 6 webinars that we do over the course of a year, including webinars on treatment-resistant depression, bipolar disorder in adults, which was the webinar we're doing right now, our coping with stress and depression, and a teen depression webinar. Those are all available for you to watch on demand on our website. And if you register on our website, we will be able to give you more information about when new webinars are happening and when you might be able to join us. I would also talk just a minute about the variety of brochures, publications, wellness guides that we have on our website. Those are all available, and you can order those. You can preview them on the website, or you can order them. You can order them in bulk amounts if you're working with a group. And please don't hesitate to contact us if you have more information about those. And if you're in Massachusetts, in the New England area, we do have mental health care consultations. It's a unique service that we provide. It's a hands-on service that allows us to really help you as a family meet with a skilled counselor, discuss your concerns, put together an action plan. We provide referrals to clinics and programs, and we have a sliding scale available there. So if you're in the Massachusetts area, that's something that I would definitely recommend you look into. And we have another website in addition to our Family Aware site that I think is really important for a lot of what's happening right now around the country when it comes to the mental health care system and everything about it, in which we're looking at how it can be fixed, how it can better serve those that are dealing with mental illness and those families that are trying to help them. It's our Care for Your Mind website, and it's careforyourmind.org, and it's in collaboration with our partners at the Depression and Bipolar Support Alliance, and really some interesting information there that I think you'd find very useful. Finally, we are going to be asking everyone to complete our online evaluation about the webinar, and we will then send you, if you complete that survey, we will send you our free copy of Bipolar Disorder, Stories of Coping and Courage, which is a really wonderful brochure that gives you some real hands-on information about other families that have been living with and dealing with bipolar disorder in their midst. And I'd like to take just one more moment to thank Dr. Youngstrom for joining us in preparation and review of this webinar. You'll see the other clinicians there, Dr. Scott Aronson, Tylo Deckersbach, David Miklovitz, Lorene Riley-Harrington, Gary Sachs, and, of course, Dr. Youngstrom. And we'd love to encourage everyone to spend some time on our website and really look at thanking our sponsors, Allergan and Synovian, and folks like you. It's your donations that allow us to really continue doing these, providing these free opportunities for families from around the country to learn more about the issues that they're facing when it comes to issues like bipolar disorder and depression. So again, thank everyone for joining us. We are always available via our website, and on that website you'll also see our phone number and a direct email address. We're always available to be helpful in any way that we can. Our goal is to support families that are dealing with these very challenging issues and to get people well. I'm going to turn it back over to Susan now to begin jumping into the question and answer session. Susan?
Thank you very much, Marlon. Just so for those who are not able to stay, I'm going to go ahead and push out the survey link so you can take that at any time and let us know what you thought and how we can do better and what you really liked and what you think you're going to do with the information that we've provided tonight. So, Dr. Youngstrom, got a question from somebody who's having trouble regulating sleep. How do you get into a good cycle?
So, getting into a good sleep cycle is one of the best things that you can do for yourself, and you've probably started to see a lot of discussion in the popular media about blue light and whether that is affecting our sleep. The science behind that is surprisingly strong. About 12 years ago, we discovered a cell in the human eye whose only job is to look for blue light. And when blue light comes in, it tells the brain sun still's up. And so the blue light in our cell phones and our laptops and TVs is more than enough for our brain to get confused and not start doing the things that it normally would do at night. So it doesn't make melatonin. It doesn't change the body's core temperature. So one of the things to try is turning off the lights or even getting blue blocking glasses and seeing if those will help. And they don't work for everyone, but for the people that they do help, it's a dramatic difference. So trying to minimize the amount of light at night, possibly using blue blocking, also making sure that you get up at a regular time, can really help. Your body is like a pendulum that does best when it has a regular rhythm. And so getting to bed at a regular time, getting up at a regular time, and trying to follow natural patterns of light and dark can make a huge difference.
Okay. Great. There's a lot of questions about how do you really know that it's bipolar disorder?
That's a fantastic question. It's always a very difficult condition to recognize. The more extreme the ups are, the more frequent the ups are, the more that it's a clear change in functioning. The more episodic the presentation, the more confident I am that we're dealing with a mood disorder. The challenge is figuring out how to recognize it without waiting for something catastrophic to happen. Again, making that analogy to heart disease, you could have high blood pressure, you could have some mild arrhythmias. Is it really, really heart disease? We don't want to wait until the person has a serious heart attack to then get serious about a treatment plan. In the same way, we can't be 100% sure that it's bipolar disorder unless the person gets floridly manic and gets hospitalized, but it would be ideal to recognize it sooner and try to prevent that rather than waiting for that to make the diagnosis 100% clear. So what would be ideal in the real world would be to have a range of treatment options available. So for acute mania, definitely medication, definitely look at hospitalization. But for a milder presentation, maybe it's mania, maybe it's hypomania. Think about what would be other things we could do to stabilize it and prevent it from escalating all the way to a mania. And so here the exercise, the reducing stimulation, the reducing exposure to light at night, all of those things, if it gets all the way to a mania, those aren't going to be effective treatments, but they could be very effective preventions or early interventions to prevent something getting all the way to that point.
Excellent. We've had some concern from people who are living with bipolar disorder and how to handle themselves around other people, how to talk with their kids, how to interact with their, through their personal relationships. And I would think that there would be some of the therapies would be particularly helpful on that. What do you say?
I think that's a wonderful question and a very one that really needs a very nuanced response. It's like different layers of the onion. So at the innermost circle, how you talk about it and communicate about it with your closest family members and closest friends is one issue. And then the outer layers of the onion are things like, do you talk about it on a job application? Do you discuss it with coworkers? Do you, if you need to miss a day or two of work, Do you explain it's because I'm dealing with a mood disorder, or do you focus on something else as an explanation or excuse? Excuse for the absence. I think that you're absolutely right that this is a great place for a good talk therapist to help sort through what's the best type of communication for the particular relationship and the particular situation. Relationships are complicated, and one size is not going to fit all. So having someone that you trust with your interests at heart to help you sort through that can really be hugely helpful.
There's a couple of questions about the behavior of people with bipolar disorder. It sounds very much like these are from family members. One is about the negative behaviors of lying, manipulating, being nasty, being irritable, being easy to provoke anger, which could be dangerous in some situations. So one is about sort of why do these things happen, and the other is, how do you deal with someone's physical aggression? Let me just say, when we were talking about the steps you can take when someone is manic, my understanding is you don't want to do anything that's going to put yourself in danger. And this is also the situation where if you can have your plan in advance, you've already agreed on the steps that each of you is going to take in the event that those situations arise. But, for someone who doesn't have the benefit of that kind of plan, what are they going to do?
Again, a very important, very real-world question. So where does the irritability come from? Unfortunately, with bipolar disorder, it can come from many different places. When people are depressed, this is one of the places where thinking about this has really changed over the last 10 years. We're realizing that the irritability is often comes right out of the depression, and people feel very, very grumpy and prickly and surly. And we used to think that was more a child or adolescent thing, but we see it very much with adults too. When a person gets hypomanic or manic, they have a lot of energy and they're focused on trying to do something, and they become very angry very quickly if someone tells them no and tries to stop them. And that it's possible for a person to be depressed and lash out, but it's even more likely when the energy level is high and they're impulsive, that if someone tells them no, digs their heels in and confronts them, that'll escalate very, very quickly. So in the talk, we recommended don't get into a pitched battle with them. Don't get sucked in and feed the emotion. But the other really crucial thing is, as you said, Susan, is if it looks like there's any risk of aggression, get out of the situation, protect yourself first, and if the other person is also potentially a danger to themselves, then that you need to contact 911. The most important thing is keeping everyone safe. The good news about this is that as long as everyone is safe, we have ways that we can stabilize the mood, and once the mood is stabilized, then the communication and the talking become possible.
So when someone is manic, can they really not control what they're doing?
When someone is terribly manic, they're completely out of control. It's possible to become psychotic when you're manic, and in younger age groups, bipolar disorder is actually a more common cause of psychosis and completely out of control behavior than schizophrenia.
We've had a surprising number of questions about the book that you had spoken about at the beginning, and people are curious for more information about it, or if you could just remind us.
Mm-hmm. The book is called Touch by Fire by Kay Redfield Jameson. It's available in paperback on Amazon, and so Kay Jameson was writing for an academic audience, so it's very carefully researched, and she's a very good writer, but it's not a novel. It's got some weight to it. The other one that could be great, also very worth a look, is called An Unquiet Line, and that is her autobiography about her own experiences living with bipolar disorder and coming to recognize it in herself. And for the people who are asking the questions about how do you share this with people close to you, what do you choose to share with people at work, Unquiet Mind is a very thoughtful, very candid exploring of exactly those issues in the later chapters. And that, of the two, that's the easier read. But both of them very, very worth a look, very highly regarded on Amazon.
Is there, I can remember talking with other people, and there's this idea that mood disorders are sort of a spectrum and not necessarily super clear-cut on, what exactly you have and all of that. But is it more important to treat the symptoms, or is it more important to identify what it is and do the treatment accordingly? Great question.
Another way of phrasing it is asking, are mood disorders a question of degree? Everyone can experience depression, and at some points in our lives we have almost none. Sometimes we have a little bit of it. Sometimes we have a medium amount, and occasionally we may be unfortunate enough to have very high. It's just like temperature. Is it cold or warm or hot today? But there's always a temperature. It's just a difference of amount. Versus the idea of categories, there are, you either have the illness or you don't. You have bipolar disorder or you don't. And researchers have tried to statistically test, does the evidence fit the matter of degree continuum approach better, or does it look like there are categories, people with versus without? And really, the data mostly seem to say it's a question of degree. So it's not as important to obsess about, is it bipolar 1 or bipolar 2 or psychothymic disorder, and more to think about, okay, when we say the difference between bipolar 2 and bipolar 1, looking at it that dimensional way, what it's saying is, we know that a person with bipolar 1 has the potential for even more extreme highs, getting to a point where they're seriously impulsive, often out of control, and it may be risking their marriage, their relationship, their job, versus the hypomania tells us it's not an ordinary depression, and they could get more impulsive, but it's not to that extreme. So I think that sort of understanding, do we have to worry about both the ups and the downs is crucial for organizing the treatment. But then, and this is a big change in my own thinking, because I've put a lot of time and effort into trying to improve the diagnostic categories. But I really think that the difference is knowing that a person has bipolar 2 instead of an ordinary depression changes the treatment a lot. bipolar 2 versus some other type of bipolar disorder, psychotonic disorder, that doesn't change the treatment so much. Either way, we know we need to plan for managing the downs, and we need to plan for also preventing and managing the extreme ups.
All right, let me try and close out on what I hope is a hopeful note. What do you see as the future in treatment and perhaps even cure?
I really think that the future is bright, and I think that the analogy that many of us are starting to make, that bipolar is a brain disease compared to what we're learning about heart disease, I think really helps lay out the path for research and for living with it. So what we're learning, we have great advances in heart care, and while we could do a really good quadruple bypass or a transplant, it's an excellent treatment. It's a treatment of last resort, and same way we've got excellent treatments for mania now, but we would want those to be treatments of last resort. So what we're doing in heart care is trying to promote lifestyle changes, exercise, better diet, and with bipolar disorder, learning more about exercise and diet, but especially sleep. And the apps that are available now on smartphones to help us track our daily routines, and the wearables, the Fitbits and iWatches and things like that are really making it possible for us to do a much better job of tracking our own exercise and what we eat and our sleep. And I really think that's going to give us much more leverage over our lives, and that's the place that if we have to fight bipolar disorder, and we get to choose the battleground that I would want to have to fight it on is the prevention and the wellness. And the other thing that we're learning with that, to really end on a message of hope, is that what people with bipolar disorder want is not just take away my symptoms, it's give me the rest of my life back. And many of the treatments that we have for mania and depression, we've been focusing on eliminating the negative, but the improving exercise, improving diet, improving sleep. Those are things that don't just help prevent the symptoms, they accentuate the positive. They give people the rest of their life back. And so that's the reason I think that the next 10 years are going to see some of the biggest improvements that we've seen yet in the management of this condition.
Well, that is incredibly exciting and certainly something to be watching out for. I'm going to take a moment here and just push out the survey for those who missed it the first time. And I want to thank Dr. Youngstrom so much for being with us. And Marlon, thank you so much for sharing about Families for Depression Awareness. And to all of you, thank you so much for tuning in. Visit our website for more information, and good night.